Hello everybody. Today we are going to discuss about SIADH. This was the question which was asked in DRNB Critical Care exam in 2019. So definition, syndrome of inappropriate antidiuretic hormonal secretion or uh, ectopic or is a condition in which body makes too much of antidiuretic hormone, that is ADH. This syndrome is characterized by hyponatremia, concentration of the urine and dilution of the blood. The patient has inadequate amount of blood. Patient has an adequate amount of the blood, but it is more dilute than the norm. So SIDH causes the body to retain fluid, resulting into the decreased electrolyte imbalance. Balance. So antidiuretic hormone is produced by an area of a brain, the hypothalamus, and this hormone is stored and released by the pituitary gland. So ADH controls how body releases and the conserve of water or helps the kidney control amount of water a body loses through the urine. Now about the pathophysiology, to best understand this syndrome, a sound knowledge of underlying physiology is essential. The kidney have an important role in fluid and the electrolyte homeostasis. In general, the homeostasis is achieved by the adjustment to the urine output and electrolyte composition of urine and serum. So fluctuation occurs with both intake and the administration of the fluid and solute into the body with subsequent hormonal response and feedback. The release of ADH by the posterior pituitary gland is regulated by signaling network involving osmosensor, barosensor, and also volume sensor in the body. In renal system, these sensors are located in the collecting duct of the kidney, and ADH is the key regulator of water absorption here. The pituitary gland is stimulated to secrete ADH when the body senses hypertonicity, allowing the absorption of the water back into the circulation by means of increased water permeability and sodium absorption in the renal system, thereby preventing diuresis. When this occurs, urine becomes more concentrated and the urine output decreases. Alternatively, when the body senses hypotonicity, the ADH secretion is suppressed, allowing for less concentrated and the high volume of urine output. So ADH secretion also plays a role in the sensation of thirst. Now about the risk factors, CNS disturbance leading to the increased ADH release like stroke, infection, trauma, bleeding in and around the brain, head trauma, hydrocephalus, GBS, and multiple sclerosis. Cancers of lung, GI tract, genitourinary tract, lymphoma, sarcoma, and malignant tumor production of the ADH. Drug-related includes but not limited to SSRI, carbamazepine, chlorpropamide, and cyclophosphamide. Administration of hormones such as vasopressin, desmopressin to treat other medical conditions. Pulmonary diseases like pneumonia, less frequently asthma, respiratory failure, atelectasis, and pneumothorax. Hormone deficiency like hypopituitarism, hypothyroidism, surgery, HIV, hereditary, and idiopathy. Now, signs and symptoms. SIDH makes it difficult for body to get rid of excess water. This causes buildup of the fluid as well as abnormally low sodium level. So symptoms may be mild and the vague at first, but tend to build. Severe cases may involve these symptoms like loss of appetite, confusion, nausea, muscle cramps, weakness, depression, irritability, restlessness, fatigue, memory problems, strange behavior and the signs will be the other symptoms will be vomiting, hypothermia, tremor, confusion, seizure, stupor, coma, edema, problem with the balance. So the diagnosis is usually begin with the taking history, physical examination. Often the urine sample is also required. Blood test, specifically one called as ADH test, can measure circulating ADH level in the blood, but it is difficult to obtain accurate level. According to the University of Rochester Medical Center, normal value of the ADH is ranges from the 0 to 5 picogram per milliliter, and higher level could be the result of SIDH. Most cases of SIDH are accurately diagnosed with the serum and the urine sodium and osmolality value as well as clinical presentation, and the results may like if plasma osmolality is less than 275 mmol per kg and urine osmolality is more than 100 mmosmol per kg, check the urinary sodium concentration. So SIDH is likely diagnosis if urinary sodium is more than 20. If urinary sodium is less than 20, reconsider the volume status of the patient, as this usually reflects the intravascular volume depletion. Serum uric acid will be low. Now the treatment. SIDH is characterized by the presence of hypotonic hyponatremia in the context of inadequately diluted urine given the hypoosmolarity in the plasma, in the absence of low effective circulating volume. In most, if not all cases, the most common cause of hyponatremia is non-osmotic release of arginine vasopressin. Exclude the following condition for definitive diagnosis, that is renal failure, adrenal insufficiency, severe hypothyroidism, as well as non-osmotic physiological stimuli of the AVP secretions. For example, volume depletion, pain, stress, and nausea. Causes of SIDH are multiple and varied and ranges from the medication side effect to underlying malignancy. If there is no clear cause following initial investigations, or if there is repeat admission with hyponatremia, consider systematic radiological investigations such as computed tomography of the chest, abdomen, pelvis, and a magnetic resonance imaging of the head. Fluid restriction is the mainstay of treatment for SIDH. However, the degree of restriction necessarily will vary and depending on the patient's ability to excrete electrolyte-free water. Once SIDH has been definitely diagnosed, use first formula to estimate electrolyte-free water clearance through urine upon plasma electrolyte ratio. If urine upon plasma electrolyte ratio is between 5 to 10, then commence fluid restriction of 500 ml per day. If urine upon plasma electrolyte ratio is less than 5, then commence the fluid restriction of 1000. If it is more than 10, then there is no excretion of the electrolyte free water and the fluid restriction is unlikely to be beneficial. The principle of the fluid restriction for the management of SIDH should be clearly understood and followed. The degree of the fluid restriction can be difficult to calculate, initiate, and maintain for patient in hospital and is also added burden to the patient themselves as well as nursing staff. When urine to plasma electrolyte ratio is more than 10, almost no amount of the urine water restriction will result in rise in serum sodium because free water is being retained and the process will promote hyponatremia. So the what is first formula? So dilute urine may be considered to have isotonic portion and the electrolyte free water portion. The proportion of the electrolyte free water and the isotonic urine can be measured by the ratio of effective solute between the plasma and the urine. So restriction of the water intake to less than the amount of electrolyte free water excreted will cause plasma tonicity and hence serum sodium to rise. The amount of electrolyte free water can be cleared from the kidney will therefore affect the patient's response to the fluid restriction. Clinically useful equation simplified by the FURST for estimating free water clearance is urine upon plasma electrolyte ratio measured into the urine. So it is calculated as follows, that is urine sodium concentration plus urine potassium concentration upon serum sodium concentration. So undertaking effective fluid restriction. Important feature in the practice of fluid restriction includes the use of fluid balance sheet, bedside notices, and the removal of excess bedside fluid. Paramedic staff such as volunteer with the T rounds must be made aware of importance of the practice. Daily assessment of the urea and electrolyte and clinical review must be made on all patients who are fluid restricted. Now, specialist review. Patients in whom fluid restriction is not advised or patients who have a poor response to fluid restriction after 24 to 48 hours should be reviewed by consultant with experience of treating hyponatremia such as consultant endocrinologist who may consider pharmacological all treatment such as tolvaptan and demiclocycline. However, the later treatment may cause problem with subsequent chemotherapy, for example, candidiasis and impairment of renal function. Now, treatment with tolvaptan. By binding to and blocking V2 receptor, vaptan drug can be used to correct hyponatremia and SIDH. This is an attractive therapeutic avenue because it tackles the cause of underlying fluid restriction. The SALT on and SALT 2 trial have shown that serum sodium can be safely improved in patients with hyponatremia through the removal of excess free water, producing additional benefit in the patient's quality of life as measured by 12-item short form generalized health survey score. The prompt correction of hyponatremia in patients with SIDH may be associated with reduction in hospital stay. Before initiating tolvaptan, it is essential to remove any fluid restriction and ensure that patient can drink in response to thirst, as correction of hyponatremia can occur too rapidly if they are combined. So tolvaptan should be initiated at a dose of 15 mg orally once daily, and serum sodium should be monitored 6 hourly after starting treatment to exclude overly rapid correction. Clinical experience is limited and its use should be restricted to consultant endocrinologist, oncologist, nephrologist, or other appropriate specialists with significant experience of using this medication. We suggest that it should be prescribed as a single dose, not as a repeated prescription. In many cases, just 2 or possibly 3 doses are required. Now, treatment with the demiclocycline. The United Kingdom, demiclocycline is licensed to treat hyponatremia associated with SIDH secondary to the malignant disease, where fluid restriction is ineffective and the patient does not have liver cirrhosis. So demiclocycline should be started at a dose of 150 mg 3 times daily, assess after 3 days and increase if necessary. However, the patient's response to demiclocycline can be unpredictable and it has slow onset of action. The evidence base is sparse and frequency of its known hepatotoxic and nephrotoxic side effect is unclear. Thank you guys.